The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanek, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Welcome, everybody. We are here for the next episode of TMD Demystified, and I'm Tony Urbanek. I appreciate you showing up and taking your time for a review of TMD. Hopefully you can learn something based on my experience with this problem. For any newcomers, I'm an oral and maxillofacial surgeon who treated TMD for the first 36 years of my 50-year career surgically with various types of temporomandibular joint surgery. In fact, each and every kind of potential surgery I have experimented with and used. Some of them I've done multiple times, 2,000 cases over the first 36 years, half of them through an arthroscope and half of them through an incision in front of the ear, open joint surgery. But 15 years ago, I decided that surgery was not going to be the long-term answer for this problem, and did some rather extensive but rather simple research and figured out really why no one could figure this problem out. And I've talked on that many times, but figured out that the common denominator for TMD, temporomandibular joint disorder, is chronic inflammation within the temporomandibular joint. Actually, it almost stands to reason that would be it, but no one up until this time during my research focused on chronic inflammation within the temporomandibular joint and how to best handle chronic inflammation. That is a topic maybe for a different time, or you can refer back to earlier podcasts where I talk extensively about chronic inflammation, the symptoms, and how each symptom of TMD is directly created by chronic inflammation. And when you make the chronic inflammation disappear, the symptoms disappear. But today, the topic and title of today's episode is TMD. What's the worst that can happen? TMD, what's the worst can happen? Most cases are pretty vanilla as far as I'm concerned. Patients come in with 2 years, 5 years, 10 years, 20 years of temporomandibular joint symptoms, and they've usually been run around in circles, usually circles by the professions, doing all kind of treatments either for the symptoms or nothing at all, in an attempt to handle these disparate symptoms, very disparate symptoms that vary by time and position all over the place, all over the upper body. But today, I ran across a case recently, actually last Thursday. Patient presented to me with what was a good example of what's the worst that can happen. If you have TMD, it's not a mild disorder. It can change your life negatively over a long period of time. I've mentioned before that actually I have documented 3 cases, one on videotape. She made a videotape and said that she had contemplated, 3 patients, separate patients, had contemplated suicide because they couldn't get any help. No one could lead them to any kind of help, and they were at their wits' end. Fortunately, none of the 3 completed that thought. But I guess that would be the worst that could happen. But today we're going to talk about a patient that I saw Thursday that really struck me in a very negative way about my God, this is um, really, really terrible. So I have an X-ray. Let's go right to the X-ray, and we'll talk from that. Because when I introduce myself during a consultation, I always look at the X-ray after I introduce myself, and this is an X-ray that I took of this patient that had been undergoing prior some rather extensive dental treatment. You can see a couple dental implants in there that have not been loaded yet, and one dental implant that had been. But the deciding factor on this particular patient was this little, I think you can see it here. Not really. Let's go back to share. You can see a wire ligature on the right side of this patient toward the inferior border. And that ligature told me exactly what had happened to this patient about 15 years ago, because that one ligature told me what operation was done for her. It told me where it was done. It told me who the surgeon was. And it explained partially of why she presented with her chief complaint was, I can't open my mouth. And on examination, she could only open to 15 millimeters, basically one finger breadth is as far as she could get open, which was significant. But she had been locked that way. I said, how long have you been unable to open? And she said 7 weeks. So to be specific, this procedure on her right side, where the ligature is at the inferior border, that wire ligature, was performed roughly, I don't know the exact date, but it was performed roughly 15 years prior to my examination last Thursday. But she could not open fully. She could not open beyond 15 millimeters. And what that proved to me is that she definitely had a meniscus or disc, which was dislocated anteriorly, which was blocking her from opening fully. The real problem was that not just that she couldn't eat anything, chew anything that was more than liquids, but it's very dangerous because if she had any kind of accident or emergency and had to have any kind of emergency surgery, there would be no way for an anesthesiologist to get an endotracheal tube into her trachea for the anesthesia without extensive difficulty at very best and a lot of preparation, or a tracheostomy would have to be performed by a surgeon on an emergency basis. So the point is that she had a big liability in the fact that she couldn't open beyond 15 millimeters, which could literally lead to a catastrophe, a death, because she couldn't open her mouth because she had TMD that began when she was, and her history showed, when she was 20 years old. And this problem began when she was about 20 and she began having just clicking, click, 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 which was the indicator that the joint was going bad. As we've talked about before, the joint itself is nothing more than a ball and a socket. And in between the ball and the socket is a little cushion, disc or meniscus, which generates the chronic inflammation once it's damaged. And so she had a history of bruxism, clenching and grinding, which over a period of time in her early adolescence damaged the temporomandibular joint and damaged the meniscus to the point where the ligaments that hold the meniscus get loose and it starts to click. And for several years, it clicks, but no pain. And then after a while, the ligaments get really loose and the disc comes all the way out here in front of the socket, balls up into a little ball in front of the socket. Now, when the patient tries to open, they bump into their own cushion, which is sitting right there in front of the socket until it gets past it. The disc clicks back, usually with a louder pop, or usually much louder noise and some pain. And she admitted that yes, there were years that that was going on, that had happened, and that she ignored that. And then finally, she had the surgery 15 years ago and was somewhat relatively pain-free for about a year. And then the symptoms on the right side began to appear again. And she ignored the symptoms because they were periodic. Chronic inflammation is periodic. It comes and goes. The inflammation goes up. The body spots the inflammation, does some things to drive it down, with or without drugs, with or without any help, with or without any treatment of the symptoms. The body will spot that chronic inflammation, drive it on down. That's why TMD symptoms are periodic, up and down, but every time the symptoms come back, every time the pain comes back, it hurts more, stays longer, goes away for a while, comes back, hurts more, stays longer, goes away. But that's what occurred on her right side for roughly 14, going on 15 years. But the left side was kind of symptom-free until about a year ago. And then she began having symptoms on the left side, similar to the symptoms she had on the right side. And they were doing the same thing as far as clicking and then popping. And then 7 weeks ago, it went to a total block. And the disc meniscus was out in front of the fossa, the glenoid fossa, and she couldn't open beyond 15 millimeters. And she had been that way. And she had gone back to her PCP, she had gone back to an ENT, she had gone to her general dentist, and she finally ended up in my office for consultation last Thursday with her chief complaint, along with a lot of those other symptoms, headache, earache, jaw pain, neck pain, tinnitus, subjective hearing loss, etc., with the inability to open beyond 15 millimeters. So fortunately, I'd like to bring up this other view if I can. There we go. So this is just an easier way to look at this. Both joints themselves, this is the left joint, shows considerable amount of degenerative change, and the right joint shows about equal amount of significant degenerative change. You're not going to see the meniscus or the disc in front of it, but I can promise you a couple things. I know what happened with surgery on this side and what surgery was done. That basically the disc on this side that was surgically treated 15 years ago is just like mush right now. And the disc on this side, where it's locked, and she could tell that this is the side, this is the side that is now locked, where the disc is out in front. Well, fortunately, I was able to get her open enough to take impressions. And the way I did that was to inject the joint itself with local anesthesia. It's an easy thing to do if you know what to do. And if you don't know what to do, I would not recommend it. The injection has to be done into the joint itself. If you inject too much or in the wrong place, you can easily anesthetize the facial nerve and you'll get lip droop and facial droop for several hours until the anesthetic wears off, or in a catastrophe, you damage the facial nerve when you're doing that injection. It could be permanent or semi-permanent. So I would caution anyone who wants to inject a temporomandibular joint to have a lot of experience injecting that particular joint, or you can cause some significant damage. But we're able to get her open enough. I think we got her open to about 30 millimeters, which is enough to put um, a scanner inside the mouth and get a scan done, get impressions done, so that the device can be made that unloads the temporomandibular joint. I think that we've talked about unloading the joint long enough, describing why it's done, how it's done, why it is so significantly an improvement on any kind of surgery. It's a significant improvement on any kind of treatment of the symptoms themselves, and extremely effective on unloading the joint and causing the chronic inflammation to go away. So we got impressions, and she will be back in about a week or so to get the device and start on her trip to decreasing the inflammation and allowing the chronic inflammation to decrease. It's not a complicated system. It's not a complicated treatment. It is very predictable. The common denominator of TMD is chronic inflammation in the temporomandibular joint. It's provable. Of course, we have a study, independent university study through MTSU, giving the statistical analysis based on 3,000 successfully treated patients. But even more so, in my mind, it is reasonable to assume that if nonsteroidals work so well, but only for a short period of time, nonsteroidals being ibuprofen or aspirin, will give significant decrease in chronic inflammation, but only for a few weeks at best. A couple weeks, maybe 3 weeks. You'll get some benefit out of nonsteroidals, which do nothing more, nothing less than decrease chronic inflammation. But if you unload a joint, whether it be a knee with crutches, or a inflamed elbow with a sling, or a temporomandibular joint with a device and protocol, because you don't use it just any way you want. You have to follow a protocol that allows the initial decrease in inflammation to go as rapidly as possible, protocol being 24/7 for 2 months, then nighttime only the rest of your life. It does the same thing as nonsteroidals, but over a long, extended period of time, and beautifully self-controlled by the patient. If they run into a problem, it's very simple. You just put the device in more during the day. Once you get into nighttime, if you go to the dentist and open widely to get a crown made or get the implants restored that this lady had, you're going to open widely. You're going to tend to stir up the inflammation in the joint, at which point the simplicity is you just wear this device more during the day, but never 24/7 again. The 24/7 is only for the first 2 months. Beyond that, you don't want to go beyond 2 months 24/7, but you can use it an additional 8 hours a day. So all you're doing with the whole process is to decrease inflammation, just like nonsteroidals decrease inflammation. And everybody agrees that nonsteroidals work really good. Everyone agrees, but only for a short period of time. So why not a device and protocol that does it long term? Logical, makes sense. So what's the worst that can happen? Well, this patient, when you can't open for 7 weeks and you're on liquids and you're having constant symptoms, headache, earache, jaw pain, neck pain, constant, not even intermittent anymore, because after a while the intermittent changes to constant, and you can't open your mouth. That is pretty close to the worst that can happen to a patient with TMD, and it's not that unusual. It's not that unusual at all. So if you would like to learn more about how to do this, you can go to our website at www.urbanictmj.com, where all the information is, where you can take the course. If you are a dentist and want to do this, take the course and become a provider for the device and protocol. All the information is there. If you are a patient who thinks they may have TMD, temporomandibular joint disorder, better known to the public and the professions as TMJ, there's a list of doctors throughout the United States who are also licensed to do this device and protocol, which we had to name the Urbanic device and protocol because on survey, the patients wanted to call it literally. The survey leader on the survey, they wanted to call it Save My Life device. And it sounded too corny to me. It sounded more like the Vegematic of TV fame. So we just had to drop back and call it the Urbanic device and protocol. So that's the worst can happen. I hope with a little visual from on an X-ray, you can see some of these points and have an experience sometimes with patients like I had that if you don't know what to do, now you know where to go to find the answers, where to go to find the information, how to treat these patients successfully. With that said, I look forward to the next time, next week, when we will pick another topic, pick another title, and we'll talk about TMD Demystified. I am Tony Urbanik.